most microscopic surgery, melanoma, all stages management they have asked, molecular biology, and in BCC they have asked about clinico-pathological and management. Special note on SLNB in melanoma. Isolated limb perfusion, actually I have not studied, but in Divyang's note it is there actually. So
मेरे वाले में भी है, मेरे वाले में भी है.
That I have not studied and not added here. And management of appendicular tumor. Oh, this one I thought it was skin appendicular. Anyway, then regional. All stages of melanoma they have asked. So we have to give evidence for margins, SLNB, and adjuvant immunotherapy.
और अभी अपने फैट में मॉलिक्यूलर क्लासिफिकेशन भी आया था इसका.
Melanoma. Yeah, Avneet had sent that. I have just written one page as to which are the driver mutations that you'll have to write. Again, you can divide the whole in chronic skin damage, low, high, and non-related to skin UV damage. So in molecular, as we know it from benign, it becomes dysplastic, in situ, and carcinoma. So first we will write it this way. Melanocytes will become benign nevus, they become dysplastic. There are two different growth patterns, radial, vertical, and they become metastasis. So what we all know is BRAF is already there. So when it is dysplastic, on either side, something that starts with D you can add. CDK, CDK2NA along with BRAF, then dysplastic on the side CD1, and between the two growth pattern, loss of EK adherent. So because there will be loss of adhesion, so there will be transformation from radial to vertical growth. Then from this locally, it becomes metastatic with TRPM1 driver mutation. So in a horizontal diagram, you can write benign dysplastic, in situ, and carcinoma. Here, the number of single mutations, number of other mutations keep on increasing. So at the end, when it becomes carcinoma, there is increased mutation burden. One, driver mutation starts with BRAF, then there will be alteration in TERT. So combination driver mutation BRAF and TERT, NRAS and TERT, which is promoted by CDKN2A, leading to carcinoma changes, leading to metastasis. So finally, TP53 and P10 is driver mutation. So this, broadly you remember. However you want, you can write. So in skin, they have asked about layers of skin. So starting with basal, spinosum, lucidum, granulosum, and corneum. This we all know. Then you can add about first it should be epidermis, dermis, subcutaneous. In epidermis, basal, spinosum, lucidum, then granulosum, and last is LGC. Okay, corneum. In dermis, it is papillary, reticular, along with appendicular components like sweat glands, hair follicles, and sebaceous glands, and supporting and supplying blood vessels, subcutaneous fat, blood vessels, and nerves. So, according to the origin, keratinocytes will give rise to SCC, BCC. BCC special mention about origin from the follicular basal cell, melanoma from melanocytes, Merkel cell from neuroendocrine cells of the skin, that is Merkel cells. So Langerhans dendritic, they'll give rise to histiosarcoma. So each of these epidermal supporting nail unit supplied by all these blood vessels and nerve, appendages unit, all of these will have benign component, carcinomatous component, and non-epithelial is neuroendocrine, that is Merkel cell. So in benign you can write all omas. Then in carcinoma, we all know melanoma, BCC, SCC. Keratoacanthoma is a special entity which is taken out from SCC, and it's mentioned separately, even having benign and malignant entity. Merkel cell you can mention. Then the nail unit, appendage unit, that is hair follicle, sebaceous gland, apocrine, eccrine, sweat glands. So it can be all oma, poroma, cylindroma, syringoma, hyadenoma. All of this will have a carcinoma component that you can mention. Then the nail unit, that is hair follicle nail unit, it had different name. You can write malignancy arising from the nail unit. So this is one classification. Then coming to melanoma. Melanoma, I'll go into the NCCN. In each, when we are discussing stage itself, I'll mention about evidences also and how to remember them as well. So when it comes to melanoma, origin is from melanocytes, as we all know. Broadly, there is 4 morphological types and there are many more subtypes and variants. So what we have to broadly remember is superficial spreading, nodular, acral, lentigo, maligna. Most common is superficial spreading and second most common is nodular. In nodular, you should also remember it has only vertical growth phase and that is why it's a very aggressive variant. Then coming to other variants which are related to chronic exposure or may not be. Amelanotic, schizoid, splitzoid, desmoplastic. These are the different variants of melanoma. Here, what you have to remember is ABCD, asymmetry, the border, color differentiation, diameter more than 6 centimeter, and evolution of the lesion, added with firmness on palpation and nodularity. So, if there is any evolution of skin lesion, can be pigmented, non-pigmented, with variation of any of these types, then there is high index of suspicion. So, when you have high index of suspicion of a lesion, you will do minimal margin biopsy. That means to say, when you won't decide your margin based on thickness here. You still don't know whether it is melanoma. What if it is a non-pigmented variety? You don't know if it is a melanoma. So you will first do a minimal margin biopsy if it's a totally excisable lesion. If you get a very big, bulky, irregular, without margins, then you can do incisional biopsy for that as well. Next, then you will after getting this biopsy, you will assess for its thickness, ulceration status, mitotic rate, microsatellosis if present, if there is a predilection for lymphovascular, angiolymphatic, or perineural invasion, whether there is association of desmoplasia. What is the importance of each of these? They have asked even what are the prognostic factors of melanoma. We will have to be writing pathological prognostic factors is breast lobe thickness. This is about the primary breast lobe thickness, ulceration status, dermal mitotic rate, margin status, microsatellosis, LVI, PNI, angiolymphatic invasion, presence of desmoplasia. When there is increased desmoplasia, the role of SLNB you can still consider, but there is high rate of false negativity. So now the diagnosis of melanoma is made. Depending on the thickness, you will give margins and re-excise. This is the time you will offer the patient SLNB. Now you have to know whether it is a clinical N positive or a negative disease. What you have to know in lymphatic addressing the lymph nodes in melanoma is it is prognostic. It will tell you selection of adjuvant therapy, but the therapeutic advantage of completion lymph node dissection is not proven. You will not be removing the nodes for therapeutic advantage. This is told by MSLT2 and DCOG trials. So, when it is in situ carcinoma, the margin that is expected to be given is 0.5 to 1 centimeter. Here, there is no role for SLNB. Here, NCCN also says it is not recommended. Next, coming to what you have to know before going ahead with stages, I will simplify the staging for you. T, N, M. T, this has 2 aspects, size, ulceration. N has 3 aspects, whether it is a occult node, clinically positive or clinically detected node, or there is in transit in satellite lesions. So that comes under N. M again has 2 things, site LDH. So you will put it in brackets as 0 or 1. So what you have to remember is for all management decision 0.8 and okay 1.1224. So is 1 second is 1.1 centimeter to 2 sorry mm 2 mm. So remember three things when you're deciding treatment. T1B, stage 2B. These are the two things what will change treatment. Anything below T1B, that is, the lesion is 0.8 centimeter, it does not have any ulceration. Then you can simply do wide local excision. No need to do SLNB. That is clear cut. Now, for 0.8 mm, it is less, but there is ulceration, or the lesion is more than 0.8 mm with or without ulceration, then you have to discuss with the patient for their willingness for SLNB. Here, there is role to avoid SLNB in this category where you can do only wide local excision and no SLNB. Then, depending on their positivity, you will decide whether to do completion lymphadenectomy or just address this micrometastasis or further on non-SLN lymph node metastasis with any adjuvant therapy. So that is the thing. What is the role of stage 2B? Beyond stage 2B, you will increase your imaging, you will at least add a PET scan, you will do MRI brain, and when you resort to surveillance of these patients with ultrasound for your node, then you will add even CT. The frequency of follow-up will become 3 monthly. So that is the that is the note that you have to keep for stage 2B. So now um, in SLNB, there are few points that you'll have to know. Here, it can be done with radio colloid or dye. It is same as you will do. There are two ways. Intra-op, I mean, you can give the dye, or before 60 to 90 minutes, you can give the radio colloid. Then do like how you do for breast. There's another way of lymph node mapping, especially in head and neck, where you use the SPECT, where a day prior you inject, you will do the imaging, you will find out the lymphatic drainage, and you will see what are the lymph node pickup, then post them next day for SLN. Those are the two ways of doing. Now you found, and another thing is about desmoplastic melanoma. There is controversial role of SLNB. Here you can use imaging for node pickup, or you can directly stage the disease by complete lymph node dissection. Now, the other points that I want to emphasize is in melanoma, SLNB followed by completion lymph node dissection is not therapeutic. So after SLNB, completion lymph node dissection can completely be avoided, and it can be taken over by adjuvant therapy. Then this adjuvant therapy is associated with better disease-free survival as well as overall survival. So when we are discussing the trials, MSLT1, MSLT2 and DCOG. MSLT1 wanted to see if less morbid procedure was done to identify occult nodal metastasis in clinically N0 patients. So they divided the patients into SLNB positive, SLNB negative. Those with SLNB positive went ahead with completion lymph node dissection. What they found, their analysis was there was no oncological difference between those patients observed or those patients undergoing completion lymphadenectomy. One, that means to say completion lymphadenectomy did not really give any therapeutic advantage, but it also increased the morbidity. So they said that okay, instead of observing, but they found that the recurrence rate earlier it was not more, but later on it increased, but not very statistically significant. So that led to a concept where MSLT and DCOG wanted to avoid therapeutic dissections and used SLNB as a staging procedure to know the prognostic factors and to decide your adjuvant therapy to address the non-SLNB nodal metastases that were not found that were left. So in this, what you have to write is your surveillance is ultrasound based radiological assessment, where 3 monthly, 6 monthly, you will image the patient. Then you will decrease the frequency of imaging. When you pick up a recurrence, then you will resort to completion lymph node dissection. Until then, the patient will get one or the other form of immunotherapy. So this is what it's a stage-wise management. Now coming to microsatellite lesions, in transit lesion, all of this. See, whenever this comes into purview of resection, you can still resect. For example, the definition of satellite and in transit is by distance from the primary. This is the primary. You find another lesion within 2 centimeter or beyond 2 centimeter, you will call it satellite or in transit. If these lesions can be encompassed in your wide local resection followed by plus or minus reconstruction, definitely you can go ahead with surgery. Only when these are very disseminated, they don't come in the field, then you will resort to other form of regional treatment, and there is role for TVEC. So here you can add for in-transit satellite lesions if when given in your answers about TVEC and about infusion ILP, these two things. And mutational analysis, like I told you previously, for all N positive you have to do NGS, especially beyond stage 2B. But you can consider doing NGS even in the lower risk, but it is mandatory to do NGS beyond stage 3. So stage 3, stage 4, it is mandatory. Why it is important to do in previous stages? For example, they become candidates for adjuvant therapy. Then your BRAF mutation, NTRK and NRAS have a implication on your targeted therapy. So in the final histopathology, you can do them. So now coming to so when there's a question for node positive. So completion lymph node dissection is one option. You can just give adjuvant RT, or there is role for your immunotherapy. So here checkmate 238 and swab 1801 trials for your adjuvant treatment. In adjuvant, everywhere there are 3 options. That is Nivo plus Ipilimumab. This has been superior in all aspects, OS, DSS, everywhere. Pembro, there are some trials that say there is some disease-specific survival, but not OS. Then BRAF-directed therapy, that is Vemurafenib with Tremetinib. Vemurafenib and Tremetinib. So here, in any due course of treatment, what you have to remember is this immunotherapy can be given neoadjuvant, it can be given adjuvant, or it can be given as a primary therapy in an unresectable case. Even in recurrent setting, this is the combination of therapy that is used. So if the patient is received in their primary therapy one of the other modality, in subsequent recurrence or adjuvant, you will change the therapy and use. So what are the biomarkers for giving them? They really don't check for CPS scores here. They only see here is because they are very immunogenic. The only mutation NGS that they do in the panel is BRAF, NTRK, and other driver mutations. But otherwise, they don't really check for this scores or tumor burden to start on it. So these are the 3 options that I was telling: pembrolizumab, nivolumab, dabrafenib, trametinib or vemurafenib also. Okay, maybe I think it's dabrafenib. Okay, sorry. So these are the three options. So they have asked in specific about stage 3. So what are the things that stage 3 consists of? It can be satellite in transit or node positive disease. So there is role for neoadjuvant. That is the extra thing that you will be adding. And there is role for TVEC here. Everywhere you will tell whether it is resectable or unresectable. Then stage 3 unresectable, same thing. You can use all forms of therapy here.
स्टेज 3 तो वी विल गो फॉर पूरा डेफिनेटिव लिम्फ नोड डिसेक्शन ना, उसमें तो सेंटिनल लिम्फ नोड करना नहीं है.
No. And see, stage 3, there can be N0 with in transit also. In that, if it is N plus, you will go for surgery or RT. There are two varieties in stage 3. Node plus is also stage 3. In transit and satellite lesions with N0 also is stage 3.
तो इसका अगर stage 3 with N0 होता है, then also we will should go for SLN.
Yes. SLNB is the minimum staging procedure. That it is not imaging that is staging. It is SLNB is minimum for N0.
What is this NED?
No evidence of disease, I think. Yeah. No evidence of disease. So it is basically same thing. You can here, because stage 3 is very experimental. You have lot of option and you will be right, whatever you use. Because the survival benefit is not too much between these modalities. So if you resort to any of this, you're not wrong. Only in the early stages, there is, you should stick to the guidelines. Otherwise, pretty much in unresectable, in advanced stages, you can use whatever form of treatment you want to give. There are 4, 5, 6 options you have. So again in this, okay, metastatic is also a thing here. What I wanted to highlight here is there is a component of oligometastatic. Then you will challenge them with some form of systemic therapy. After assessment of response, if there is only limited disease, then you can resort to some form of local therapy in the form of surgical resection or SBRT or intralesional TVEC. So there is role for metastasectomy in melanoma. That is what I wanted to emphasize. And in advanced stages, that is stage 3 and stage 4, there is a role for MRI brain that you have to include in your workup. Then coming to some of the chemo regimens that can be used in metastatic setting. If the patient is not affordable, you can challenge them with dacarbazine, temozolomide, paclitaxel, albumin-bound paclitaxel, paclicarbo, CVD regimen, cisplatin, vinblastine, and dacarbazine. So if they ask you some risk factors, you can mention males who are elderly more than 50 years, those who have pre-malignant lesions like atypical. Pre-malignant or precursor lesion is also a question. In that, congenital nevus, atypical nevus, then mucosal melanosis, then dysplastic nevi, and lentigo-maligna in situ, melanoma in situ. These are all pre-malignant lesions. So atypical moles or dysplastic nevus, increased mole count, Fitzpatrick skin type, those who have light skin, blue eye, and red hair, sun exposed people who are in the tropicals. Then history of here hereditary in all malignancy, skin especially, there is component in the risk factors, environmental. It can be in the form of physical light, that is UV exposure, any photosensitizing agents that is being used on the skin. Then hereditary component has to be mentioned along, and immunosuppression. So holds good for all skin malignancy. And you can mention about these driver mutation that we already discussed. Then in environmental, same as we told, along the equator, increased chronic sun exposure, those who go for tanning methods. Then most microscopic, when I discuss, we can discuss even there is a new entity that has come. It's PDMA. It's a surgical technique of specimen orientation for a frozen section that I'll discuss when I'm doing PCC. So extra things, molecular testing, we went through it. This is what is asked when we go. I mean, write that molecular differentiation. You can also mention about their therapeutic implications. So pretty much in NCC, and that is what is there. But I'll summarize this for you. Just a second. Okay, so here in situ invasive with N0, N plus stage 3, metastatic stage 4. So your routine clinical examination, imaging, a metastatic workup, and labs LDH is what something you have to mention, and CNS imaging beyond stage 3. Then for thin, intermediate, and thick melanomas, the cutoff is 1 to 4 is the intermediate, less than that is thin, and more than that is thick. So they have propensity for lymphatic dissemination earlier than systemic, but they behave very weird. There is no sequential spread. They can still present only with systemic dissemination. So the T1B is the cutoff for your SLNB consideration, and beyond 1.1 mm, that is T2, it is definitely recommended. Between T1B and T2, it is considering SLNB. Then lymph node mapping, that's what we discussed. So what's the rationale? It is mainly prognostic, not therapeutic, and you have to write about the morbidity associated with completion lymphadenectomy. So the concept, the trial that gave standard of care SLNB positive followed by completion lymphadenectomy was MSLT1. So I told you both two dual techniques for identifying SLNB, then role of SPECT, especially in head and neck. Uh, Actually, even the thickness of the melanoma will dictate patient's choice for SLNB, where they say if it is thin melanomas, you can really avoid. But intermediate group of melanomas, if SLNB is positive and you go ahead doing completion lymphadenectomy in MSLT1 trial, this showed oncological benefit, but it was not shown for thick melanomas and N plus disease, telling that when there is already a disease, it can be occult or frank or increased risk, it is not giving any therapeutic advantage. So when you are mentioning about MSLT1, intermediate risk group will get special attention because in them there was oncological benefit than compared to thick and N plus disease. So again, as we discussed, stage 3 includes N plus in transit metastasis. Then you will here you have lot of options. You can write all of them and you're not incorrect. In stage 4, again, along with BRAF, even c-KIT mutations have special mention here, but you can mention it for unresectable and stage 3 as well. And when you write about when there is SLNB positive, there are two options. You can do completion lymph node dissection or you can give adjuvant immunotherapy. Here, when you have not done completion, you will have to follow them up. So, close surveillance by ultrasound guided lymph node assessment 3 monthly. So, this is something that you will have to add. So, when you pick up a recurrence, then you do your lymph node dissection. So, 4th monthly or 3 monthly, then 6 monthly. So, this is about melanoma. I forgot to tell about margin trials, I think. Just a second, it is here. Margin, basically you divide it into whether it is carcinoma in situ, whether it is, and by thickness you decide. So when you're writing about your margins, you can write if it is in situ, recommended is 0.5 to 1 centimeter. Less than that is for thin melanomas, 1 centimeter is enough. For intermediate risk, they say 1 to 2 centimeter, but more than 2 mm, it should be more than 2 centimeter. So more than 2 centimeters, 2 centimeter. So 1 to 2 centimeters, 1 to 2 centimeter. Less than 1 mm is 1 centimeter. For in situ, it's 0.5 to 1. So which are the trials? WHO intergroup Swedish, European and UK trial. All of them, they had different margins spanning from 2 centimeter to 5 centimeter. Beyond 2 centimeter, they did not find any advantage, but it increased morbidity, local morbidity. And most of these inclusion criteria included tumor thickness between 1 to 2 mm only. So most of them were thin to intermediate melanomas. So when you add about this, you can write about WHO intergroup Swedish, European and UK trials. That is one thing I wanted to tell. Then, okay. So they've asked about differential DDs for skin lesion. These are the list that I have mentioned: seborrheic keratosis, actinic keratosis, keratoacanthomas, cutaneous horn, nevus sebaceous lesions, benign nevus. So this group, they are precursors for melanoma. Congenital nevus, atypical nevus, mucosal melanosis, lentigo maligna, dysplastic nevus, atypical splits tumor. Then coming to BCC. Like we already mentioned, you'll have to mention about the sun exposure and association, and exposure to photosensitizing agents, treatment for your skin for acne, psoriasis that led to increased development of BCC, hereditary factors. The hereditary syndromes that are associated with BCC were nevoid BCC syndrome, that is Gorlin's syndrome, Rombo, xeroderma pigmentosa, Muir syndrome, oculocutaneous albinism. So these are some syndromes that you can mention. Then in BCC, there are some things that we'll have to know. Your treatment basically depends. No, by nature, BCC is very locally aggressive. Lymph node metastasis is not found. They are usually found in critical places like in the face, where you cannot give wider margin and it is not even required. There are two thoughts for this. One, you do minimal cosmetic surgery, and in these areas when they recur, you can still resort to same local treatment and surgical treatment with minimal margins every time they recur. And here you should know about the low and the high risk types. What divides them into low and high risk types? So there are some okay, there are two columns that you'll have to know. One, if, their appearance. If they are nodular, by differentiated, they are well differentiated, well demarcated, they lie in extremities or in the trunk. They measure less than 2 centimeter. If they don't have LVI, PNI, they come into low risk category. And the margin that is recommended for them is less than 4 mm. So it can lie between 2 to 4 mm. All the high risk varieties come in the head zone. So this is the head zone where it will be nose, eye and lateral cheek and ear there, and any side with more than 2 centimeter. And if they are poorly differentiated, not well made out, they are multiple and they have morphiform, basosquamoid type, and if they are multiple sclerosing, they all come in high risk category. So for them, the recommended margin is more than 4 mm. So it can be 4 to 6 mm. All your management, first you will decide your management depends on which risk category you are dealing with. The lower risk category, since they are usually superficial, nodular, you can resort to some of the local forms of therapy. They have the same recurrence rate and they have same prognosis compared to wide excisions done. So Here, some of the options of local therapy are curettage with desiccation, shave removal, 4 standard excision with margin. You can give radiation therapy. Non-surgical options can also be tried for low risk. So this is the special mention category where you can use topical imiquimod, topical 5-FU, photodynamic therapy using photosensitizer, that is topical aminolevulinic acid or porphymer sodium, or cryotherapy. So when you're writing for low risk, there is surgical and there is a special mention of non-surgical. These surgical, especially the standard excision and RT, can also be used for high resection types. So when there is positive margin, you still resort to better cosmetic techniques like Mohs surgery, and there is a special mention about this PDEMA. It's expanded as peripheral and deep end-phase margin assessment. There are 3 techniques that are mentioned under this. We will discuss it after this. So when there is positive margin, you can do Mohs or other forms of surgery. You can do re-excision again with wider margins, or you can give RT for non-surgical candidates. Then coming to high risk. In high risk, what you have to remember is you will give wider margin, as I said, more than 4 mm. Here, usually non-surgical is only RT as an option. You will not use any local topical therapies that we used in low risk, and there is no role for shave excision and what did we discuss first? Yeah, shave excisions and your electrodesiccation. So most standard excision and RT, they have role. Here there is role for adjuvant RT because high risk lesion per se they are high risk because they have increased local recurrence rate compared to the low risk. So you will usually give them some form of adjuvant, mostly RT, especially when there is PNI positive. So they've asked about the management of advanced BCC. Advanced BCC can be a situation which is unresectable, very extensive and making it unresectable, or there can be node positive disease, or it can be metastatic. Here you have to take MDT opinion. There is consideration for neoadjuvant systemic therapy, or you can give some form of local therapy, follow it up with adjuvant, or you can just give palliative radiation, or you can subject the patient to clinical trial. So in neoadjuvant, adjuvant, or primary therapy, this Vesmodegib and Sonidegib, and immunotherapy, that is semiplimab has role. So these are the 3 agents which are used for systemic therapy, either in neoadjuvant or adjuvant or in primary metastatic
ये तो
setting.
हेजॉग इनहिबिटर है ना, डेजिप वाला।
Yeah.
और
Hedgehog
ये
inhibitor.
सेमीप्लिमैब क्या है?
It is an immunotherapy. Semiplimab. So follow-up, history and physical examination, only if symptomatic do imaging. Otherwise, you will do complete examination. You will give them skin protectants. Some adjuncts like nicotinamide and multivitamins are implicated for prevention, especially if they are hereditary syndrome associated. Genetic counseling and analysis is also recommended. So this, with hereditary syndrome, there'll be closer surveillance, and you can use nicotinamide for chemo prevention. And 4 cutoff for your margin. Low risk, keep it below 4 High risk, go above 4 So in SCC, you have to know their T size. Here also, the management is depending on their risk category. They are grouped into low, high, and very high risk. Depending on these risk categories, you will give margin as well. So if it is low risk, 6 is recommended margin, high risk 1 centimeter. If they are very high risk, then you have to give some form of adjuvant therapy, mostly RT. And here there is role for chemo prevention, and there is concept of field cancerization when you come for squamous cell carcinoma. So what makes them low risk, high risk, or very high risk? the
So
larger
let
lesion.
me know कि
Poor
this NCCN classification is only for head and neck squamous cell carcinoma. It's not applicable for squamous cell carcinoma of other side.
squamous cell carcinoma of skin of other sides, it's not included. It is,
It
because
is
head
in
and neck
this
comes in high
risk
risk.
they have included, but this staging is belongs to head and neck squamous cell cancer. It's not for
No,
other.
no, no, no.
When
This is
I was
skin
reading
lesion,
AJCC ना, तो AJCC ने ये बोला है कि इसकी AJCC की जो staging है, that staging belongs only to head and neck squamous cell carcinoma.
which you're telling high, low, and very high. This one, this group category.
नहीं, staging.
हाँ,
TNM
correct,
staging जो है ना squamous cell carcinoma of skin
correct,
की,
correct, correct. Yeah, skin is not. That is when they have mentioned that vermilion border of the lip is not
हाँ,
included.
तो this is only for head and neck squamous cell carcinoma, not for others.
That four
This
centimeter.
हाँ, but this risk
No,
factor में they have
this is
included subsites,
yeah.
so we can
This is
see.
different because all your management depends on this only. Your margins will come depending on this only. See, the funda of squamous cell is you will address the primary, you will address the node. You basically surgery predominates over RT. Then you will add adjuvant or you will give some form of neoadjuvant. That is all. So depending on the risk, you will add some other things so that it will not come back. So in low risk, very high risk is more than 4 centimeter any location. It has got poor differentiation. It has got desmoplasia. It is depth of the thickness or level of invasion is more than 6 mm with invasion beyond subcutaneous fat, and there is nerve involvement. PNI is positive, LVI is positive. These come under very high risk. Then what constitutes low risk? Trunk extremity less than 2 centimeter, well differentiated, not in a previously irradiated or an immunocompromised. Those don't that grow rapidly. There are no neurological symptoms, meaning the nerve is not involved clinically. They are well to moderately differentiated and they have less than 2 mm thickness or invasion not beyond subcutaneous fat. There is no perineural or lymphovascular invasion. Anything that does not fit into low and high risk will come, very high risk comes under low risk. Then all your treatment will be based on this. Here again, suspicious lesion, you will take a biopsy. If they come as squamous cell, then you will categorize them and whether they have associated any epidermal dysplasia because of field cancerization, you will look for. So you will look for primary, you look for regional, you will rule out distant metastasis as well. So they have given some preventive measures that you can mention. That is use of daily sunscreen, use of nicotinamide, and topical agents for field cancerization. That is 5-fluorouracil based treatment. Then ablative techniques, chemical peels, cryotherapy, curettage and electrodissection, photodynamic therapy, retinoids, and capecitabine for severe refractory that has progressed on oral retinoids. These are the special mention. If in case they ask about in field cancerization with respect to skin with confluent epidermal dysplasia, you can mention all of these. And especially in precursor lesions of skin also, you can make a special mention. Then coming to stage wise. So let us see what we do for this kind of first as node only. Okay, low risk. Like we saw in BCC, again here, all that electro desiccation, shave removal, and your 6 mm margin comes for low risk. And in case there is recurrence, there is role for re-excision, or you can give R. In very high risk, what is the consensus is there is special mention for imaging for local staging as well as lymphatics, and there is confirmation of lymph node by SLNB is an added thing here, and there is role for neoadjuvant therapy in very high risk, and here you give one or the other form of adjuvant therapy, especially when you have pathological adverse factors like PNI, and there is large by size, node involvement clinically, all of this, then you will add some form of adjuvant. In locally advanced or unresectable, nothing extra. You will you will address the primary with minimal conservative surgeries, or you'll do then you can resort to giving RT or neoadjuvant. That is what they've again mentioned about the same thing. Now nodal assessment. Here, if there is N plus disease by palpation or by imaging, then you will confirm by FNA and core biopsy. If it is negative, you can reevaluate clinically, or they've given CT with contrast, repeat FNA. So if it is negative, repeat FNA or resort to core biopsy or excisional biopsy. If it is positive, then you will have to do CT to assess the size, number, location. You will do metastatic workup with PET CT and or CT abdomen TAB. Then if it is operable, then you will see whether it belongs to head and neck or trunk. If it is operable head and neck, then we will either do surgical or RT, irradiation. If it is trunk or extremities, excision of primary tumor and the regional lymph node dissection followed by RT. If it is unresectable, then you can give some form of systemic therapy or RT. So this topical treatment we saw. Okay, these are the systemic therapy options. Since it is squamous cell, cisplatin based regimens. So cisplatin or clinical trials in when you can use it concurrently with RT or only cisplatin. Carbopacly also can be used. Cetuximab, just like your head and neck. Any of these therapies still advocated. Since it is squamous cell of the skin, semiplimab is also having role along with pembrolizumab. That is also given. Neoadjuvant therapy also is the same. You can give cisplatin, fluorouracil or cisplatin or capecitabine. So this is what is new that I found in NCCN. So there's something called PDMR technique. So it is also known as complete margin assessment. So it's a descriptive term for surgical technique that will allow you for high quality histologic examination where the entire margin, peripheral and deep, is assessed at a time. So you will basically convert a 3D tumor into a flattened topographic complexity, that is 2D. So you will show off all the bulk over the flattened thing. That flattened thing you will use two technique so that you can orient them into a flat slide. That is Tübingen muffin technique or Tübingen torte technique. So by definition, it is nothing but complete margin assessment with complete margin assessment. So you will use a surgical technique that allows for a high quality histological. You will visualize all the margin and as well as interpret them. So there are three techniques that are described under this. That is Mohs, Tubin torque and Tübingen torte and Tübingen muffin technique. So these three have been told. So a surgical procedure can be described as PDMA if and only if the following criteria are met. So they have told four things. Entire marginal surface of the surgical specimen is microscopically visualized and histopathological analyzed. So here turnover time is not big. That is told in the fourth point. So the time interval between the steps of process and your your feedback, that should be in a very quick manner. So the entire margin of the specimen is microscopically visualized and analyzed for the presence of cancer. The margin surface will include peripheral and complete deep margin. That's point number one. The surgical specimen is oriented with respect to the surgical site and marked in a manner such that any positive identified on the specimen can be located and re-excised. Like we discussed in the morning, how they color code the specimen, it is similar to that. Here you will process it in such a way that you are communicated well and you exactly resect that represented area. Surgical margin of any re-excised tissue is again entirely visualized and oriented as above. This process is repeated until no further cancer is identified at the surgical margin or until further excision is not anatomically possible, especially when there is proximity to major vessels and nerves that cannot be compromised. The time interval between steps of these processes is rapid enough to prevent significant size or shape changes in the wound bed that would decrease the accuracy of orientation. So basically, they want to tell that you will visualize both the margins, that is peripheral and deep. You will orient in such a way that the pathologist can communicate the exact place where you have to re-excise or refashion it. You will keep doing this process till you get a negative margin. You will stop if you are reaching critical areas, and you will do this process rapid enough that the surgical bed will not shrink or change in shape, such that your representative margin is changed. So what are the principle is, basically they want to visualize all the margin peripherally and deep. That is what is the whole concept of this pdma. Then you will mention about these three techniques. Then there is a checklist. They have just mentioned one checklist here. What were the examples? That is most Tübingen muffin, Tübingen tort technique, versus the other things that we do, the shave, bread loaf, perpendicular sectioning, quadrant technique, square procedure. These are not PDMA. They are others where they say you cannot visualize all the margin at a time. You have to, separate them as quadrant and orient them in a way that in a single slide or section you cannot visualize all the margin. So here, even our microtomes are used intra-op only. So, or the vicinity is very near where you cut, you will use the microtome and you will, that's most microsurgery basically. So here your checklist will be entire peripheral margin, deep margin, the wound bed is oriented and marked, the pathology specimen is marked, the histological analysis of the resection or re-excise margin is accurate, uh, is the process of excision and complete histopathological is repeated until no cancer is further found in the periphery or the margin or the surgical bed. And the time interval should also be rapid. So these are some of the principles of PDMA. Coming to most microsurgery. So basically, it's like a conservative surgery where you are trying to spare maximum tissue. Still, you are precise in removing the cancer, and it was developed by Frederick Morse. It gives you high cure rate, and it can be used in primary setting, in unresectable crucial areas of BCC, SEC, and some form of melanomas, especially in situ lesions and thin superficial melanomas. So here the technique, before the present technique, they used to use some form of chemicals in order to freeze that, so that you could get comparison like how we formal like fixed specimen basically. So you used to use a chemical fixative 24 hours prior, so that the tissue is fixed and you can assess them microscopically. Now we do it on the same day. It is performed by removing thin margin of the tissue circumferentially around and deep to the clinical margin of the skin tumor. So you will bevel at 45 degrees, then you'll start cutting thin slices. It is rapidly frozen and sectioned using a cryostat microtome. So the turnaround time is about 15 to 30 minutes. You will take horizontal section till you reach negative margins. Here the indications that they have given is critical area, especially the H area that I mentioned, that is the nose, eyes, lateral chin and ear, central face, genitalia, uh, and especially in whom you anticipate risk recurrences like immunocompromised genetic syndrome previously irradiated. In them you will try to be minimalistic at the initial so that they will subsequently require more surgeries. And especially when the recurrent setting and in unresectable also, you can resort to most, meaning you will not give them deeper margin positive. For example, you have a large unresectable extending up till bone, you can still do most and just give them some form of adjuvant or systemic therapy. And for aggressive features, you can resort to all aggressive forms where recurrence rate is high. Here what you can do is there should be training for this technique, good lighting, you should have equipments to cut the specimen, and you should know how to interpret it. So the technique is tumor is first outlined prior with a local injection. So you would want to delineate the tumor. Then, prior to removal, the tissue layer is carefully oriented by placing small, okay, at 12 o'clock, 3 o'clock, 9 o'clock, you'll just give H marks so that you will know which is where. Then, thin margin of the tissue is removed circumferentially all around and deep to the debulk tumor defect. And this is oriented and it is interpreted. So here you will use staining, that is HND and toluidine blue. The clinical significance here is they did not find much of difference in local recurrences when they gave more margin, and this was cosmetically better. And for especially multiple recurrent lesions, this was found to be more helpful. So that is why it got broader clinical applicability. So you will basically debulk, you will delineate, you will debulk, then you will orient the specimen, like there is different quadrants, then you orient them, then whichever site it is positive, you will go and re-excise that area till you get a negative margin. In Merkel cell, I just wanted to add some few, just tell in brief. Merkel cell, the origin is from neuroendocrine skin. Predilection is in elderly. So they are associated with UV exposure, viral etiology, and immune suppression state. They have propensity for lymph nodes. So they more than 30% of them spread to nodes. So that is why lymph node assessment and metastatic you have to rule out by mandatory PET scan, and SLNB is mandatory for all stages. SLNB will guide you the adjuvant treatment. If it is N plus, then you can do surgical treatment, radiation, or you can give neoadjuvant therapy and resort to surgical resection. So there is role for immunotherapy also in Merkel cell. So these are 4-5 points I just wanted to write. It is otherwise similar to squamous cell carcinoma management of primary and lymph node. Here what you have to remember is all of them will need SLNB in N0. In N plus, you will have to do some or the other form of lymph node dissection or irradiation. Then there is role for pembrolizumab as well. Yeah, that's all I think. Yeah. Right. Okay.
हो गया हो गया
हाँ, दैट्स ऑल।
है, वो एक अलग है, जिसको नहीं है वो अलग है, और एक नोडुलर मेलेनोमा टाइप सी है। तो इसमें 9 पाथवे हो गए हैं। तो 1 पाथवे है सुपरफिशियल स्प्रेडिंग मेलेनोमा, 2 पाथवे है लेंटिग्नो मेलेनोमा। जो लेंटिग्नो वाला है वो हाई सन डैमेज, क्यूमुलेटिव सन डैमेज है, और सुपरफिशियल वाला लो है। फिर थर्ड इज डेस्मोप्लास्टिक मेलेनोमा, फोर्थ इज स्पिट्स मेलेनोमा, फिफ्थ एक्रल मेलेनोमा। तो ऐसे फिंगर, मैंने 5 फिंगर होती है, तो एक्रल वाला वो होता है, टिप्स होता है, फिंगर टिप्स। तो एक्रल वाला 5 है। ठीक है, सुपरफिशियल स्प्रेडिंग याद रहता है। लेटिग्नो मेलिग्नो मेलेनोमा टाइप 2 है। हाँ, तो ये भी ठीक है। तो यू वाला सबसे लास्ट है। यू वैसे भी अल्फ़ाबेटिकल ऑर्डर में सबसे लास्ट में आता है, तो वो 9 में है। ठीक है, और ब्लू मेलेनोमा, ब्लू नेवा 8th है, कंजेनाइटल 7th है, और म्यूकोजल मेलेनोमा 6 है। तो एटलीस्ट पूरा नहीं लिख पाओ तो इतना ही लिख के आ जाओ, तो भी कुछ नंबर तो देगा वो। ठीक है, फिर ये हाई यूवी रेडिएशन और लो यूवी रेडिएशन। तो हाई यूवी वाला अपना ये वाला था, लो मेलेनोमा नीवस, और हाई वाले में हाई सीएसटी और डेस्मोप्लास्टिक मेलेनोमा हाई वाला है। ठीक है, तो इसमें तुमने ये ब्राफ एंड रास ये सब बता ही दिया है, इससे काम चल जाएगा हमारा। ठीक है, तो इसके पाथवे इतना तो मत पढ़ पाएंगे हम, पर एटलीस्ट वो ऊपर वाला लिख के आएंगे तो कुछ नंबर मिल जाएंगे। फिर तुम्हारा एक ये ABCD वाला अच्छा पॉइंट था, एसिमेट्री, बॉर्डर इरेगुलरिटी, कलर, इवोल्यूशन ऑफ द चेंजेस, ये एडल्ट में होता है। ठीक है, और एक इसमें ग्लासगो 7 चेक पॉइंट्स होते हैं, वो भी वही वाले हैं। तो मेजर में साइज, शेप एंड कलर, और बाकी सब जो है वो माइनर में है, पर बच्चों में ये वाला यूज़ करते हैं। ठीक है, तो बच्चों में पिंक कलर, नोड्यूलर मेलेनोमा, ENF, लीजन्स ऑफ नेल्स, ABCD के दूसरे फंडे हैं। पीडियाट्रिक में ए मेलोनेटिक, ब्लीडिंग बम्प, कलर यूनिफॉर्मिटी, डायामीटर, कलर का तो कलर ही है, अल्सरेशन और पायोजेनिक ग्रैनुलोमा, ये पीडियाट्रिक है। नेल्स में ये ABCDF है। तो इतना तो नेल का अलग से नहीं आएगा, पर पीडियाट्रिक का थोड़ा अलग से आ सकता है। ठीक है, तो हमारे पास जो डायग्नोसिस में कोई भी मेलेनोमा आएगा तो हम थोड़ा तो डायग्नोसिस लिखेंगे। तो जो हम लिखेंगे बायोप्सी वायोप्सी, इसके अलावा ये कॉनफोकल माइक्रोस्कोपी, एक डर्मास्कोपी, ये थोड़े थोड़े मॉडर्न वर्ड्स लिख देना। डिजिटल डर्मास्कोपी बेस सिस्टम, AI के बेस पे भी आजकल हो गया है। AI को हर चीज़ में घुसा दिया है, पर स्टिल हिस्टोपैथोलॉजी ऑलवेज अ गोल्ड स्टैंडर्ड। ठीक है, तो क्लासिफिकेशन तो लिखने की ज़रूरत नहीं है, बर्सलो लिख देना, बर्सलो से काम हो जाएगा। ठीक है, तो बायोप्सी एक्सीजन वर्सेस इंसीजन तो तुमने ऑलरेडी बताया है। एक्सीजन बायोप्सी 1 to 3 mm मार्जिन के लिए लेते हैं, बहुत ही स्मॉल लीजन से। अगर इंसीशनल बायोप्सी यूजली प्रेफर करते हैं लार्ज लीजन्स के लिए ऑन फेस, पाम एंड सोल एंड नेल। और नेल में बायोप्सी में नेल फोल्ड, नेल बेड या नेल मैट्रिक्स। ठीक है, तो S100, मार्ट 1, HMB 45 और सॉक्स 10, ये सब हमको करने हैं मेलेनोमा में। ISC, फिश एंड मॉलिक्यूलर टेक्निक्स, सब कुछ भी टेक्निक से कर सकते हैं। तो असेंशियल डायरेटा जानने की ज़रूरत है। मेलेनोमा, बर्सलो थिकनेस, अल्सरेशन प्रेजेंट है कि नहीं, माइटोसिस नंबर कितना है, माइक्रोस्कोपिक सैटेलाइट्स, वस्कुलर इन्वेजन एंड एडिक्वेसी ऑफ द सर्जिकल मार्जिन, वो तुमने बता ही दिया। तो स्टेजिंग इन्वेस्टिगेशन 1 and 2 में ज़रूरत नहीं है, 3 के बाद हमको पेट स्कैन और ब्रेन MRI करवाना है। ठीक है, तो ये सब मैंने इसके लिए नहीं खोला था। तो तुम्हारे जो ये ट्रायल्स हैं वो इसने एक ही टेबल में दिए हुए हैं। आई थिंक ये पुरानी डेविटा की टेबल है। ठीक है, स्वेडिश, इंटरग्रुप, ब्रिटिश, फ्रेंच एंड WHO। तो फॉल्स नेगेटिव रेट इसका 12% है सेंटिनल लिम्फ नोड बायोप्सी का। तो ये MSALT1 तुमने बताया था कि इंटरमीडिएट में आया है, बाकी वो उसमें नहीं आया है, हाई ग्रेड में कोई फ़ायदा नहीं है, पर इंटरमीडिएट ग्रुप के लिए रिकमेंडेड है। और फिर पॉजिटिव अगर सेंटिनल लिम्फ नोड आता है तो कंप्लीट लिम्फ नोड डिसेक्शन कर सकते हैं। ये 2 RCT बोलते हैं, एक ये डीकॉग दैट इज़ जर्मन डर्मेटोलॉजिकल कॉरपोरेशन ग्रुप, और एक MSLT2। ये कंप्लीट लिम्फ नोड डिसेक्शन वर्सेस ऑब्जर्वेशन में ये दोनों ट्रायल्स हैं। ठीक है, तो डीकॉग बोल स्टॉप हो गया क्योंकि कुछ फ़ायदा नहीं है, हैंस स्टडी फिनिश अंडर पावर्ड थी, कोई डिफरेंस नहीं मिला सर्वाइवल में। और MSLT2 बोल रहा था कि 18 to 75 ईयर्स का अगर एज ग्रुप है, सेंटिनल लिम्फ नोड बायोप्सी है, तो उसको रैंडमाइज़ किया है, लिम्फ नोड डिसेक्शन करना है कि ऑब्जर्वेशन करना है। डिसीज़ कंट्रोल रेट इम्प्रूव हुआ है इमीडिएट CLND में वर्सेस अगर हम सेकेंड स्टेज में करते हैं, पर OS बेनिफिट कुछ नहीं मिला है। तो एक फाल्क डाल्गडोस का कुछ मेटा एनालिसिस है, इसने बोला कि 4 RCTs को कंपेयर किया, इमीडिएट कंप्लीशन लिम्फ नोड डिसेक्शन जो है विथ ऑब्जर्वेशन डिलेट को, देयर वाज नो सर्वाइवल बेनिफिट फॉर CLND। ये छोड़ो। तो सैटेलाइट मेटास्टेसिस की डेफिनेशन क्या थी? लेस देन 2 सेंटीमीटर फॉर द प्राइमरी मेलानोमा को सैटेलाइट बोलना है, मोर देन 2 सेंटीमीटर को इन ट्रांसिट बोलना है। ठीक है, इसको मैंने खोला था इसके लिए तुम्हारा। ठीक है, तो ये तो तुमको सब पता है, इंटरल्यूकिन 2, BCG, रोज बेंगॉल स्टेन, ये सब कर देना। वो कहाँ गया? ये आइसोलेटेड लिम्ब परफ्यूजन। तो आइसोलेटेड लिम्ब परफ्यूजन पे क्वेश्चन आया है। मेल्फेलान मोस्ट कॉमनली यूज ड्रग है, सिंगल एजेंट है, उसके साथ साथ एक्टिनोमाइसिन D एंड TNF अल्फ़ा यूज़ करते हैं। ओवरऑल रिस्पॉन्स रेट इसका 90% है और मीडियन कंप्लीट रिस्पॉन्स रेट 58% है डिपेंडिंग ऑन द एजेंट। तो अकेला मेल्फेलान यूज़ करेंगे तो 47% है, मेल्फेलान प्लस एक्टिनोमाइसिन D यूज़ करेंगे तो 45 to 65% है। इसका स्क्रीनशॉट लेके तुम अपने उसमें नोट्स में ऐड कर लो, एक ये वाला और एक वो क्लासिफिकेशन वाला। ठीक है, फिर एक होता है आइसोलेटेड लिम्ब परफ्यूजन और एक होता है आइसोलेटेड लिम्ब इन्फ्यूजन। इसमें इसका डिफरेंस भी पूछा था ना, क्या होता है परफ्यूजन और इन्फ्यूजन में?
That circuit something, but I also don't know in specific.
एक में लिम्ब में टॉर्निक्वेट बांधते हैं, किसी को याद है क्या?
No, I have to study. I also don't remember.
ठीक है, बाकी तो तुमने बता ही दिया। निवोलुमैब और ये सब 1 साल के लिए देना है, ब्रैफ में ये 3 साल के लिए देना है, डेब्राफेनिब एंड ट्रामाटेनिब 3 साल के लिए देना है, निवोलुमैब पेम्ब्रोलिज्म 1 साल के लिए देना है। इपीलुमैब लेस प्रेफर्ड क्योंकि इसकी टॉक्सिसिटी थोड़ी ज़्यादा होती है। ठीक है, keynote 001 is for pembrolizumab and 66 for
मेलेनोमा का तो वो था सर 006।
दिखा तो रही हूँ। पेम्ब्रोलिजुमैब में 001 है चेकमेट, निवोलुमैब के लिए 066 है फॉर चेकमेट, और इसका ओवरऑल रिस्पॉन्स रेट है पेम्ब्रोलिजुमैब का 26% एंड चेकमेट का है 32%। इसलिए जो निवोलुमैब होती है वो ज़्यादा प्रेफरेबल है एज़ कम्पेयर टू पेम्ब्रोलिजुमैब। ठीक है, तो अगर ज़्यादा याद नहीं आए तो एटलीस्ट 001 और 66, चेकमेट 66 है और की नोट 001 है। ठीक है, जो मैकेनिज्म ऑफ एक्शन तो हम लिख ही देंगे थोड़ा बहुत।
Then only those names of the
हाँ,
trial.
001 and 66.
Oh, sorry, that's why I just left it. We can just go glance that. Maybe I'll take that screenshot and add so that we'll have it in one note.
आइसोलेटेड लिम्ब परफ्यूजन है, ये इन्फ्यूजन नहीं है, परफ्यूजन है। इसमें हाई ड्रग कंसंट्रेशन देते हैं ट्यूमर एरिया में ताकि सिस्टमिक टॉक्सिसिटी लो हो। तो आइसोलेटेड लिम्ब परफ्यूजन अलाउ द टू रीच good results on survival and quality of the patient life without toxic effects on the systemic chemotherapy को अवॉइड करते हुए हम दे सकते हैं। तो लिम्ब परफ्यूजन कंसिस्ट ऑफ 3 फेजेस होते हैं इसके। एक सर्जिकल डिमोलिशिंग फेज, नोड डिसेक्शन एंड वेसल प्रिपरेशन। दूसरा है परफ्यूजन फेज, तीसरा है रिकंस्ट्रक्टिव फेज। तो 3 फेजेस होते हैं। ट्रीटमेंट कंसिस्ट ऑफ आइसोलेटेड लिम्ब फ्रॉम सिस्टमिक सर्कुलेशन, परफॉर्म अ लिम्ब परफ्यूजन विथ साइटोस्टैटिक ड्रग ऑफ फॉर 60 मिनट्स देते हैं विथ एक्स्ट्रा कार्पोरियल सर्कुलेटिंग टेक्निक। क्या कर रहे हैं? आइसोलेटेड लिम्ब को परफ्यूज कर रहे हैं, किससे? कीमोथेरेपी से, विथ साइटोस्टैटिक ड्रग फॉर 60 मिनट्स विथ एक्स्ट्रा कॉर्पोरियल सर्कुलेशन टेक्निक। इसमें ब्लड ऑफ द लिम्ब को हीट करते हैं 41.3, हाइपरथर्मिक है वाला, है ना। 41.3 टेम्परेचर पर लाएंगे, फिर उसको इंजेक्ट करेंगे एट हाई कंसंट्रेशन एंड कंटिन्यूस सर्कुलेशन ऑफ द ड्रग इन द लिम्ब इंक्रीज द। इसमें जब टेम्परेचर बढ़ा हुआ होगा तो वो सेम फंडा होगा, उसका अपटेक जो होगा वो बढ़ जाएगा फ्रॉम द ट्यूमर एंड डायरेक्ट इफेक्ट होगा। तो डायरेक्ट इफेक्ट में डायरेक्ट पेश मर जाएगा या फिर हाइपरथर्मिया होगा, उससे डैमेज इंड्यूस्ड और ट्यूमर सेल्स डिक्रीज ड्यू टू एडाप्टेबिलिटी ऑफ द ट्यूमर वेसल। तो ये मेन है कि हाइपरथर्मिया हमने किया, उसमें आइसोलेटेड लिम्ब परफ्यूजन, लिम्ब को आइसोलेट किया हमने, उसको हम सब सेपरेट किया पूरा बॉडी से, उसमें एक टॉर्निक्वेट लगाते हैं, ठीक है। और उधर ही उसके ब्लड के टेम्परेचर को बढ़ाया और उसमें कीमोथेरेपी डाली, वो कीमोथेरेपी सर्कुलेट करेगी, वो साइटोस्टैटिक ड्रग रहती है 60 मिनट्स देते हैं। ये से परमेबिलिटी बढ़ जाती है ऑफ द ट्यूमर सेल मेम्ब्रेन इंड्यूस्ड बाय द हीट दैट अलाउ एंड क्यूमुलेट ड्रग इनसाइड द कैंसर सेल। तो इंट्रासेलुलर कंसंट्रेशन इंक्रीज हो जाती है प्लस हीट शॉक, दोनों से डीएनए जब हम हीट करते हैं किसी भी कीमोथेरेपी को तो उसकी कंसंट्रेशन प्लस हीट का अपना इफ़ेक्ट दोनों मिला के इम्पेयर हो जाता है डीएनए रिपेयर मैकेनिज्म एंड डीएनए डुप्लीकेशन करेक्ट हो जाता है। उसके कारण क्या होता है, ये सब ट्यूमर सेल्स का जो हाई प्रोलिफरेटिव इंडेक्स है, जिनका डीएनए सब रेप्लिकेशन ज़्यादा है, वहाँ पे ये बहुत जल्दी पहुँचता है और उन लोगों को मार देता है, ठीक है। तो इसका इंडिकेशन क्या है? ट्रीटमेंट ऑफ इन ट्रांसिट मेट्स, पैलिएटिव ट्रीटमेंट फॉर मेलेनोमा व्हेन रेसिडुअल लाइफ क्वालिटी टारगेट, क्यूरेटिव एंड ट्रीटमेंट फॉर सॉफ्ट टिश्यू सार्कोमा एंड लिम्ब साल्वेज सेविंग प्रोसीजर टू अवॉइड लिम्ब एम्पुटेशन। किसी के पेशेंट का एम्पुटेशन करने वाले हैं तो अब हम इसका एक लास्ट तरीका इसको ट्राई कर लेते हैं, अगर लिम्ब बच गया तो बच गया, अगर नहीं बचा तो फिर तो एम्प्यूट करना ही पड़ेगा, हमारे पास कोई चांस ही नहीं है। एंड न्यू एडजुवेंट ट्रीटमेंट टू रिड्यूस द बल्की ट्यूमर्स एंड अलाउ सक्सेस कंजर्वेटिव मैनेजमेंट लाइक सर्जरी। और इलियाक लिम्फ नोड डिसेक्शन मैंडेटरी है इसके साथ साथ, और हमको कभी कभी इलियाक भी परफ्यूज करना पड़ता है। तो क्या क्या इंडिकेशन है? इन ट्रांजिट मेड्स, पैलिएटिव ट्रीटमेंट फॉर मेलेनोमा व्हेन रेसिडुअल लाइफ बहुत कम बची है, क्यूरेटिव एंड ट्रीटमेंट ऑफ सॉफ्ट टिश्यू सार्कोमा। पेशेंट को एम्प्यूट करने वाले हैं तो उसको अवॉइड करने के लिए ट्राई कर सकते हैं, एज ए न्यू एडजुवेंट ट्रीटमेंट भी ट्राई कर सकते हैं टू रिड्यूस द बल्की ट्यूमर, उसके बाद उसमें लिम्ब सैल्वेज सर्जरी कर पाए। और कभी कभी इलियक नोड डिसेक्शन करना ही करना है, इलियक परफ्यूजन भी करना पड़ सकता है। ठीक है।
ऑक्सीजनेशन, ऑक्सीजनेटेड ब्लड, बेसिकली ब्लड स्टेज ऑक्सीजनेटेड, बेसिकली सीएबीजी का मशीन रहता है ना, वैसा ही है बाईपास सर्किटरी। एक्सट्रीमिटी इज प्लेस्ड ऑन एन एक्स्ट्रा कॉर्पोरियल ऑक्सीजनेटेड बाईपास, बकायदा सीएबीजी की तरह रहता है। बाकी सब सेम है, टूर्निकेट अप्लाई किया, हीटिंग डिवाइस भी होगा, पर ऑक्सीजनेशन भी हो रहा है। इसको क्यों ऐसा डबल डबल आवाज? एक सेकंड, ये परफ्यूजन बता रहे हैं, इन्फ्यूजन बता रहे हैं? नहीं, ये परफ्यूजन बता रहा था, इन्फ्यूजन बताता हूँ। परफ्यूजन वही जो प्लस हो बाईपास के मशीन। और तो बेसिकली इसमें ना वो पूरा बाईपास सर्किटरी होता है ना, तो ऑक्सीजनेटेड ब्लड रहता है, दैट इज व्हाट यू नीड टू रिमेंबर। और ऑटोमेटिक आईएलआई देखो, ये इसमें इट्स अ लो फ्लो, ठीक है, लो फ्लो है और ऑक्सीजनेशन नहीं है, ठीक है। एक सेकंड, देखो इसमें ये लोग ने वही लिखा है कि टूर्निकेट अप्लाई किया, परक्यूटेनसली कैथेटर इंसर्ट किया, उसके बाद ये हीटिंग डिवाइस तो रहता ही है, बट आप 20 to 30 मिनट्स से के लिए सिरिंज में कीमोथेरेपी लेके उसको इन्फ्यूज करते हो, बस इतना ही फर्क है। तो यू आर नॉट प्रोवाइडिंग एनी ऑक्सीजनेशन एंड देयर इज नो सीएबीजी टाइप बाईपास सर्किटरी मशीन। हीटिंग डिवाइस रहता है बट ऑक्सीजनेशन नहीं रहता, तो इसमें तुम्हारा लैक्टिक एसिड की वजह से भी थोड़ा इंक्रीज हो जाता है सब कुछ। और इसीलिए जैसे हाइपरथर्मिया के अंदर क्या था, हाइपरथर्मिया था, इसके अंदर हाइपरथर्मिया नहीं है, उसके बदले यू हैव सॉरी हाइपरथर्मिया है, पर यू आल्सो हैव द एडिशन ऑफ दिस एसिडोसिस बिकॉज ऑफ हाइपोक्सिया।
जो एक्स्ट्रा कॉर्पोरियल वाला सर्किट था वो इसमें नहीं है,
वो नहीं है, और तो उसके कारण ऑक्सीजनेशन नहीं होगा, सो हाइपोक्सिया होगा। और इसीलिए तुम्हारा शायद हाइपरथर्मिया के अंदर कितने ड्यूरेशन के लिए वो करते थे, मुझे
60
याद नहीं आ
मिनट्स
रहा,
बोला उसने।
तो इसमें तुम समझ लो, इसमें 20 to 30 मिनट रहता है, इसमें कम हो गया बिकॉज यू आर एडिंग वन मोर कंपोनेंट। ये देखो लो फ्लो है नंबर 1 क्योंकि मशीन नहीं है, और दूसरा ऑक्सीजन नहीं है, और तीसरा 20 to 30 मिनट से, ठीक है। और मिनिमली इन्वेसिव क्यों, क्योंकि वही है स्टैंडर्ड रेडियोलॉजी से करके कैथेटर डाला, अंडर जीए करते हैं, टूर्निकेट अप्लाई किया, साइटोटॉक्सिक एजेंट एक्टिनोमाइसिन डी और मेल्फोलिन डाला, हैंड सर्कुलेटेड for 20 to 30 minutes using a syringe. Progressive hypoxia because no oxygenation is used. That is the only. So therefore hypoxia and acidosis ये दोनों रहते हैं.
नीचे
That is the only difference.
दिखाओ नीचे वाला तुम्हारा क्या बोल रहा है, हाइपरथर्मिया वाला।
हाइपरथर्मिया वाला ही है।
ज्यादा कुछ बोल नहीं रहा है ये,
ज्यादा नहीं बोल रहा, पर वही है, subsequent cannula inserted, extremity placed in extracorporeal oxygenated bypass circuit after a tourniquet. उसको मतलब आइसोलेट दोनों में ही करना है आपको, हाइपरथर्मिया दोनों में देना है।
Isolation is there because of circuit, there only tourniquet will prevent it from entering the system.
उसमें एक एक्स्ट्रा कॉर्पोरियल मशीन होगी, इसमें नहीं होगी, और वो ऑक्सीजनेट नहीं करेगा, वो हाइपरथर्मिया देगा, और 60 मिनट्स के लिए देना है। उससे देने का फ़ायदा क्या होगा, इंट्रासेलुलर ड्रग जल्दी पहुंच जाएगी, और डीएनए डैमेज जो हाइपर रेप्लिकेटिव सेल होंगे वो मर जाएंगे। उसके इंडिकेशन अच्छे लगे मुझे, इन ट्रांजिट में देना है, पैलिएटिव केयर ऑफ मेलेनोमा में देना है, सॉफ्ट टिश्यू सार्कोमा में भी दे सकते हैं जिसमें हम लिम्ब साल्वेज सर्जरी ट्राई करना चाहते हैं, बस एम्पुटेशन ही करने वाले हैं तो उससे पहले ट्राई दे देते हैं, या फिर एज ए नियो एडजुवेंट थेरेपी भी दे सकते हैं। ये 4-5 इंडिकेशन अच्छे लगे। ये आई थिंक मैंने सॉफ्ट टिश्यू सार्कोमा वाले बुक से पढ़ा है, चैप्टर से।